تفضل دكتور.
السلام عليكم ورحمة الله وبركاته. مساكم الله بالخير جميعا، وكل عام وأنتم بخير. نسأل الله عز وجل أن يتقبل منا ومنكم صالح الأعمال، وأن يعيننا في هذا الشهر على الصيام والقيام وصالح الأعمال. On behalf of Saudi Pediatric Neurology Society, I would like to welcome you all in this webinar. I would like to thank Dr. Faisal Swaidan for accepting our invitation for tonight. I would like also to thank Event Tرووب, who are able to host us tonight and to organize all the technical issue related to this webinar. And without a delay, I'll give the microphone to Dr. Khalid Hamdallah. Dr. Khalid is a consultant pediatric neurologist and the head section of pediatric neurology at Prince Sultan Military Medical City in Riyadh. Khalid, please, you can start.
السلام عليكم ورحمة الله. مبروك عليكم رمضان. أعان الله وإياكم على صيامه وقيامه. Good evening, everybody. Thank you for joining us. Hopefully, we will have a lovely educational evening. SPNS is honored to host Dr. Faisal Swaidan. Dr. Faisal is very well known among the neurology and critical care communities. He is an adult neurologist and neurocritical care consultant at King Fahd Medical City. Dr. Faisal is going to talk to us about neurological manifestation of COVID-19. For any questions, please send us to the question through the hashtag displayed, Saudi Pedia Neuro, or through the live chat in the YouTube, or through this WhatsApp number displayed. تفضل دكتور فيصل. Welcome.
السلام عليكم وكل عام وانتم طيبين. It is an honor to be with you in this webinar organized by the Saudi Pediatric Neurology Society. That is coming in a very critical time as we handle a very difficult disease with a lot of unknown related to this, a new pandemic. I was given the honor to talk about the neurological manifestation of COVID-19, which is something actually not new. As you know, this is not the first time we're handling coronavirus pandemic, as we had SARS-CoV-1 and we had MERS-CoV as well in 2012. And currently we're facing COVID-19, which is also a coronavirus. So we have good learning experience, good curve of learning curve from manifestation that has been reported in the past. The only problem with COVID-19 that the difficulty and the challenge of confirming the neurological manifestation, the disease itself as clinical presentation. Without delay, I would like to move on the presentation. So today we'll be covering the acute disorder that could present to any practicing neurologist, either adult or pediatric neurologist, related to the COVID-19 itself, either as initial manifestation or late manifestation. I also will try to cover also the impact on chronic and comorbidities in patients with non-neurological disease, such as stroke, multiple sclerosis, or epilepsy. The impact of COVID-19 extend through the practice of neurology around the world. And we have seen a dramatic change in the skills and clinical skills and practice related to interviewing patients, diagnostic workup, and also managing patients with known diseases in the clinic or in the emergency department. Also, the training of neurologists also affected significantly, as you know, in Saudi Council for Specialty. We're trying to modify neurology training and tailor it according to the available resources during this pandemic, which is something not easy. As you know, a neurology residency training program, both adult and pediatric, is a diverse training program that requires a vast majority of skills and rotation with other subspecialties. Coronavirus is famous by its name. The corona stands for or represent the crown, which is the spike protein. The spike protein is a hallmark of coronaviruses altogether, and it's an RNA virus. This spike protein attached to certain receptors in the body. So for SARS-CoV-1 and SARS-CoV-2, they attach to the angiotensin converting enzyme receptor type 2. And they have so much or more or less similarities in their clinical manifestation and transmission from animals to human, as well as invading certain part or organ of the body. If we move to the MERS-CoV, which is the last pandemic we had in the Middle East, this coronavirus attached to a different receptor, which is dipeptidase 4, the DPP4. And this is a different receptor, which has certain representation in the body, a different organ as well. And we can extrapolate indirect scenarios for possible presentation based on the experience driven from the SARS-CoV-1, which was probably near to, it was 2002, 2003 in China. And we can anticipate similar transmission and presentations. This diagram shows us the difference between MERS-CoV and SARS-CoV-1 and 2. Originally, all of them are coming from animal, and there is an intermediate host. This host will transmit the disease to the human in different ways, depending on the proximity or the interaction with those animals. So for example, camels in Saudi Arabia is in close proximity with humans, and you see different animals have been eaten in China, and we assume the origin of all coronavirus to be from bats. So they go in the body and they target the receptor, the spike protein target the receptor. For example, SARS-CoV-1 and 2, they go to the lung mainly and they affect the gastrointestinal tract, and they can cause systemic manifestation. And MERS-CoV also affect the lung, but it has some tendency to go to the kidney as well. And they trigger an inflammatory response in the body. And that inflammatory response could be the culprit in the neurological manifestation that the patient can have. This is one possible scenario. Another important factor we have to keep in mind in COVID-19 is the factor that is called basic reproduction number, the R0, which is the average number of people infected from one person. So if you notice in the schedule, this is a comparison between MERS-CoV with the SARS-CoV-1 and 2, and you see in the yellow highlight the reproduction number, the R0 in COVID-19 is up to 6.6. While if you go to the MERS-CoV, which we had experience in the Middle East and Saudi Arabia, it's less than 1. So you see the impact of the speed and velocity of transmission between people. And by the rapid replication of those cases, we expect to see more variability and semiology of different diseases, which probably will be, reported for the first time. The path to the CNS or the neurological system probably will described under the title of COVID-19 neurovirulence, and how does the virus go through the nervous system. So the best explanation we had till now is that it goes through the olfactory nerve or trigeminal nerve through the cribriform plate. And that is more or less similar to our understanding of the infection that we get from herpes simplex. There is also possible scenarios of transmission through the glossopharyngeal and vagal nerve through the oral mucosa. And then there's the third possibility of systemic transcirculation, carrying the virus from the affected organ, which is usually in those cases are the lungs. So the virus can hit the brain from different aspects, and from there it has different manifestations. This is the direct invasion theory. And this slide explains the transmission through the olfactory nerve. The process was described as demyelination and then going through the CSF and causing trigger inflammatory response in the brain. And if you notice, there were many cases that they were reported that the patient with COVID-19 had loss of smell, and that could be attributed to the invasion of the olfactory bulb and the demyelination process initially that can precede the respiratory symptoms or the CNS symptoms. Those are the possible scenarios. What could be, causing or triggering the CNS insult? We could have the direct infection, which is through either blood or the neuronal pathway, the cranial nerves, either causing demyelination process or the activation of the inflammatory response and passing through the blood-brain barrier. The other possibility is the hypoxic insult that can happen because of the severe lung disease. And also there is potential impact of the angiotensin converting enzyme receptors affecting the circulation and hemodynamics. Again, there is the immune, body immune response, the cytokine storm, which can be triggered by the systemic inflammatory response. And at the end, you will have either an infectious toxic encephalopathy, which is something that we see usually in a patient with sepsis, like for example, urosepsis or pneumonia, or a patient who has, gangrenous foot. Again, there is the possibility of the direct invasion, which is a viral encephalitis, either direct damage to the neurons or a para-infectious process, something that we have seen probably more or less with post-vaccination encephalitis, either because of the either passive or active particles of the virus that can trigger an inflammatory response in the brain. And there is the third component, which is something unique to coronavirus, the acute cerebrovascular disease, which has been linked strongly to the hypercoagulable status the patient have. It has been reported that those patients with coronavirus, specifically SARS-1 and 2, that they have hypercoagulable state with high D-dimer, and they're prone to have thrombosis, both venous and arterial. Could the cytokine storm be the only culprit? That is possible. So the immune system has a trigger. This trigger is provoking a strong immune response, and that immune response will start attacking different parts of the body. It's well explained in the lung. So we see what is called ARDS in the lung. We see the lung rapidly get involved, and we see the patient getting hypoxia because of the failure of the transportation of the gases in the lung. There is other possibility that the patient will have an inflammatory response, and that is before even the lung is badly affected. And that has been reported when patients who had been complaining of symptoms of encephalitis and diagnosed as cases of encephalitis without reaching extreme cases of lung involvement. So the cytokine storm is something that is possible that triggers CNS manifestation in those patients. And if you allow me, this is a little bit crowded slide, but I have given it a name. This is a new name, I think. So I've called this list as neurocovidology diseases. This is my terminology. It's not in the literature. I just invented this terminology today. And this is what is published about possible neurological manifestation related to COVID-19. So there is case report about meningitis and encephalitis. There's well-established cases about new onset seizure and breakthrough seizure in patients with epilepsy. Headache was abundant on those cases. Up to 30% of patients had headache as they either have respiratory or without respiratory disease symptoms. There is the acute encephalopathy of non-infectious etiology, which is more or less metabolic. There's cases of transverse myelitis. Again, there is the stroke, ischemic stroke, which is more common, and the hemorrhagic stroke, which is probably related to low platelet count. There is the acute hemorrhagic necrotizing encephalitis or encephalopathy, which has been reported. It was a landmark, actually, something frightening to see images of the brain in patients with COVID-19. And the attention was pulled after this case report against what can happen in the future in patients with COVID-19. Guillain-Barré syndrome, a famous disease with many etiologies, has been reported. Myositis and myalgia is well recognized in both SARS-1 and 2. Sensory neuropathy and abnormal sensation has been reported, and ataxia as well, with no confirmation of the cause of the ataxia. Is it sensory ataxia or is it central ataxia? There is also a case report about loss of involuntary control of breathing, and that was reported in the literature vaguely. However, I had many cases I had heard about many cases through my colleague who had extubation failure. After extubation, they get re-intubated immediately because of poor coordination of breathing. So they probably had upper airway obstruction, vocal cord kind of paralysis, but it has been described that the lung is good, oxygen requirement is low. However, they fail extubation immediately in the ICU. This is something to keep in mind. And probably it could be attributed to something like cranial nerve palsy or probably brainstem encephalitis. Again, I don't have clear description or imaging for my hypothesis. And the loss of smell and taste, which was probably reported significantly in many cases as initial manifestation or late manifestation in patient who had COVID-19, confirmed COVID-19. So this slide describes what I call is as a neurocovidology science, and I think it will expand with time. The list will expand, and our understanding will be, inshallah, better in the future. So this is a striking imaging of a patient who had acute necrotizing hemorrhagic encephalitis. And you see the bitemporal and deep gray matter of the thalami are badly involved. You see hemorrhage and necrosis. And that has been reported in the literature lately, and it was linked to the cytokine storm rather than direct viral infection. Again, we don't have autopsies to prove or disprove the situation. And this is, again, one case reported. I did not find a similar case with the extent of this pathology. Again, I want to move forward in the meningitis and encephalitis. I'll give you a case scenario. Probably this is the first case reported in China from COVID-19, and a patient who presented with convulsion, new onset. He had persistent hiccups, and he had pyramidal finding and with upgoing plantar and meningeal irritation. What is important here, although he had normal CT scan, he had high opening pressure and when LB was done, and he had normal biochemistry and acellular CSF. However, when he was tested for, COVID-19, PCR came back positive from the CSF. And that is very much of something which we know already from the SARS-CoV-1 2002. We had many cases who had the same semiology. They present with aseptic encephalitis, and they tend to have high opening pressure when LP is done with normal imaging of the brain. And the cell count here is something striking, that you don't have any cells in the CSF. So you have to keep your index of suspicion high, especially during this pandemic. This is another case of encephalitis. This case is from Japan. It's a 25-year-old male who again presented with seizure, again a new onset seizure. He had an LP, and this LP again shows on high opening pressure. However, this case had the cell count is up to 12 with 10 mononuclear cells and 2 polymorphs without any RBC. So you see the acellular CSF is something not uncommon. It has been reported again in SARS-CoV-1, which was a previous pandemic in 2002. The MRI features anterior temporal again, which is, support the theory of transmission through the olfactory nerve and going through the direct invasion to the CNS. Back to the same case, there is a similar case also reported from, they are different cases. This is an autopsy of a patient which I did not have imaging of. There is no MRI or CT scan. However, the autopsy was done for SARS-CoV-1, which was the previous pandemic in 2002. And they found significant load of the infected cytoplasm of neurons in the hypothalamus and the cortex, which is something we're seeing here. We see the deep gray matter and the cortical area, temporal area, badly affected with this virus. We'll move now forward to the stroke and thrombosis. Both SARS-CoV-2, which is COVID-19, and the SARS-CoV-1, which is the previous pandemic, both had been linked for hypercoagulable state, both venous and arterial stroke. You see in the picture A, you see ischemic stroke. In the picture B, you see a cortical vein thrombosis with which is related again to hypercoagulable state. It has been linked strongly to the level of D-dimer. In fact, there's a strong association between the level of D-dimer and the prognosis of those patients. And the hypothesis of disseminated intravascular coagulopathy is being proposed. And currently people are trying to introduce full anticoagulation prophylactically, actually, for patients with COVID-19 and high D-dimer. The proposal came from the United Kingdom through their guideline. We're trying in Saudi Arabia to adopt something similar. However, we're trying to be careful because of the risk of full anticoagulation that can be associated when you have somebody with low platelet, which is not uncommon. So still you can have low platelet count and you end up with bleeding. And this is the picture CT scan C, which shows a small small internal capsule bleeding in the patient again with COVID-19 because of the pancytopenia. Specifically, they have low lymphocyte count and they have low platelet count, which put them in risk of spontaneous bleeding, even without hypertension. If you do EEG for those patients, regardless of the stage or manifestation, they tend to have a non-specific EEG finding, which has been linked strongly to the metabolic encephalopathy, which is not uncommon in patients who are critically sick in the ICU. You see the bifrontal slowing. However, if you have somebody with suspicion of seizure, subclinical seizure, which is not something infrequent in critical care, it's probably something you probably expect to have up to 20% in patient with the CNS manifest involvement of pathology, which is diffuse, specifically if they have what we propose as direct invasion encephalitis. So you have to be vigilant. If you're stopping sedation in the ICU, your patient is not waking up, you have to do EEG, even taking the risk that you need to be careful with the contact with the patient, especially COVID-19 positive, in case your patient is having subclinical seizure. However, the EEG, if not associated with clinical seizure, most likely it's going to be showing diffuse slowing, which is very usual in the ICU. Transverse myelitis, this is a case report, only single case in COVID-19, which was confirmed apparently by the author by physical examination. He had sensory level, pyramidal signs, double with the sphincter incontinence. He was not able to do MRI or LP in this case. However, he attributed this finding, clinical finding, to acute myelitis. And transverse myelitis, or if you go to the whole spectrum, which is encephalomyelitis, is possible, and it has been reported in SARS-CoV-1 in the previous pandemic in 2002. Guillain-Barré, a well-known disease, commonly seen in extreme of age in children and elderly, has been also reported in cases with COVID-19. This is a case report of a patient who had the AMSAN variant of Guillain-Barré syndrome, which is acute motor sensory axonal neuropathy. And he's a 65-year-old male admitted through the emergency department with acute progressive symmetrical ascending quadriparesis, classical textbook for everybody and who's familiar with patients with Guillain-Barré syndrome. He was tested positive for COVID-19 and he had no sphincter or sensory symptoms. Again, this patient had been treated as Guillain-Barré syndrome. So I would love to highlight here, when you have a manifestation of COVID-19, given that we don't have enough information about the effective treatment available, you have to treat the patient according to the known evidence. So for this patient, he had IVIG and he improved with IVIG according to the case report. Again, we're still dealing with case report. We don't have solid evidence. Coronaviruses in general, not specifically for COVID-19, has been linked to patients who had presentation with optic neuritis, multiple sclerosis, Parkinson's disease. If tested, those patients may have been exposed to coronaviruses from different species. The coronaviruses family is extensive and probably have up to 8 species. Only 3 of them is known to be transmitted from animal to human. The other 5 is poorly understood because restricted zoonotic viruses. Before we finish, I would love to highlight on something which has evolved significantly lately, which is called the teleneurology, which is probably everybody's doing nowadays. We're trying to minimize contact with patient. We're trying to enhance our skills in managing patient distantly through telecommunication. So this is a nice guideline, or a guide actually, it's not a guideline, from telemedicine and COVID-19, released from American Academy of Neurology. And they're trying to adopt protocols from the telestroke, how to evaluate your patient distantly, what part of the examination is reliable through the video or through the voice without examining your patient. So this is a little bit challenging. You can do this in many specialty. However, as all of us know, neurology is an intimate physical examination skills, need the intimate physical examination skills. You have to touch your patient, assess the power. You have to evaluate his coordination. You have to examine his sensation. And those are a little bit difficult to be done through the telemedicine. There is a nice video in the YouTube, again, from the American Academy of Neurology, talking about telemedicine COVID-19. I would advise people who are currently working in their clinic to see this recommendation, this guide, and to watch this video. we're not only suffering in practice, we're also, our trainees, our residents and fellows are suffering in training as well. There have been many recommendations to do adjustment to the curriculum according to the available and approved rotation that could be done during the pandemic. We need to also to modify the assessment tools for them. How can we conduct exams without causing overcrowdedness? And that is something important. So the council is working hard on that. They're trying to, put emergency plans to shift and change rotation to make sure the trainee get exposed to the training requirement for certification, inshallah. And that is well done by the Saudi Council. The assessment tool, again, in the pandemic, it's going to be very difficult for a graduating resident this year. How could we conduct, assessment for their skills and capabilities? However, I think with the experience in Saudi Council, again, we have also the maturity of observing residents through the training from their first year, inshallah. We think we can graduate safely residents and fellows from neurology and subspecialties. What can we do for this pandemic? The only thing that has been proven everywhere in the world, to minimize and control this disease is the physical distancing, or what probably everybody known as social distancing. And the impact of this physical distancing is through controlling the replication number, the R0. So the power or the strength of this virus, COVID-19, is through its rapid spread and contagious rate, which is very high. If we can control the R0 and keep it below 1 by social distancing or physical distancing and hand washing and isolation and quarantine of infected people, we'll be able, inshallah, to minimize the impact of this disease, which probably has lower mortality than MERS-CoV, which we had in 2012 in Saudi Arabia. The mortality rate is less than MERS-CoV. However, because of the rapid spread across the world, we are seeing higher number of total mortality. But overall, the percentage is low, Lillahi alhamd. We don't have clear evidence what could happen in the future. Again, all of the medication which was presented by the clinical trials or guidelines are hypothetical or under research. And that's why today I'm not putting any slide about antiviral or antimicrobial medication until we have solid evidence, bi'idhnillah. With that, I would like to conclude and thank you very much.
Thank you, Dr. Faisal, for this very excellent, very informative lecture. Thanks a lot. We are getting a lot of questions asking about the attendance certificate. This webinar guarantee you 2 CME hours. So we will send the registration link to the chat. So just to move, our next speaker is Dr. Salim Al-Ghamdi. He's an infectious disease consultant from King Faisal Specialist Hospital and Research Center. He's going to share with us some new information about COVID-19 and what should we do as a medical practitioner just to protect ourselves and our loved ones. Welcome, Dr. Salim, and thank you for being with us tonight.
Bismillah ar-Rahman ar-Rahim. While I'm trying to share my slide, thank you, Dr. Khalid, for the nice invitation. I want also to extend my thanks to Dr. Samir Al-Mahmadi, who have been communicating with me before. And Bismillah ar-Rahman ar-Rahim, wassalamu alaikum, wa kullu aam wa antum bikhair, wa ash-shahr mubarak alana wa alaykum. I hope إنه بركة هذا الشهر إن شاء الله will help us all to overcome this pandemic. الصوت واضح؟
أيوة تفضل.
Okay, so I would be wearing infection control hat today. I will not talk about ID or microbiology or virology. Dr. Swaydan have been touching certain areas on that, but I would just touch base some of the epidemiology and worldwide data, then transmission, then prevention mainly. So as alluded by Dr. Swaydan, we know those coronaviruses, big viral family, mainly zoonotic, and usually they get transmitted to human through intermediate hosts, and we call that spillover. And it's either through close interaction with animal or a different interaction theory with those intermediate hosts. And one of the claimed reason is for SARS-CoV-2 is pangolins, which is one of the animal live in South Asia and have been eaten there and used for some traditional medicine. So this is one of the timelines. So as you know, the early cases have been reported as a known cause of severe pneumonia and high mortality. Eventually, the virus have been isolated and the sequence generated and the PCR invented. And going with the line, I wouldn't waste your time. I'm pretty sure that all of you had been living this experience till it was declared as pandemic recently. So the symptom is mainly respiratory symptoms and commonly fever, cough, and shortness of breath. However, recently the fever might not be the best symptom to present with. So the absence of fever doesn't rule out possibility of COVID-19 infection. Many people, they just presented with myalgia, unexplained headache, and or absence of smell. So I will go direct to the epidemiology. So as you know, we crossed 3 million worldwide a few days ago, and if you can see, the world curve is hitting up, and with the deaths, the mortality rate is about it's usually ranging from 2 to 3 and recently reaching 1. Going to the local epidemiology. So this is the daily confirmed cases worldwide with the confirmed daily deaths. So we can see the world peak. So almost the world peak is flattened now, around 80,000 cases per day, and daily mortality is almost flattened and almost declining. So this is a good observation from this chart. Our local epidemiology, we are around 20,000 cases now, and the mortality rate locally is around 1. Speaking about the total cases, about the daily cases, our curve, I think the previous curve is a little bit scary. If somebody saw this curve, it might be pretending a fast peak. However, the days is a cycle days. It's not a daily graph. So this is the daily graph. We can see we are almost slowing our curve and our peak. Looking to the R0, which has been mentioned by Dr. Suwaidan as a basic reproduction number, which tend to refer as the number of cases that been infected by one case, considering all the population are susceptible. So we are around 0.8 now, which is a good number if we maintain it. However, the R0 or R0 is very difficult to measure in such cases because, or such scenario or pandemic, because one of the concerns that we don't know all the population are susceptible, or many people have been infected and they are immune now. We couldn't trace the all positive cases or transmitted cases, so we don't know if every single case infected 1 or 2 or 3, because almost more than 80% of patients will be asymptomatic. So calculating the R0 here is very tricky, but considering the available data, it's about 0.8. But I wouldn't be putting a lot of weight on the R0 to predict where we are hitting. So, but going to the same symptomatic patients, ICU requiring patients, the number is static, which is assuring. So this is our place among different countries. So if you can see the line, I'm not sure if you can see the arrow, but this is our expectation if we were duplicating our daily cases every 10 days. So we will be sorry. Good. So could you see the screen now or not? So if we get our daily cases doubled every 10 days, we will be going toward this line, which is what we are hoping. However, we are now tending to duplicate our cases 6 days or 5 days. So that's why we are heading toward every 5-day line. However, comparing our experience to previous similar countries, we are doing much better. And looking to this line and how many incubation periods have been lapsed since the beginning of our outbreak, which is almost the 1st of March, we are hitting the peak this week. And the expectation looking to this and looking to the RNet reading, we will be declining soon. However, the continuation of the new cases will continue, and the risk of getting another wave of outbreak is possible. And the measures of social distancing and general infection prevention precaution will be mandated to avoid the relapse or the second wave. So this is looking for our deaths, and I think you can see Saudi Arabia, we are in a better shape compared to many different countries. So this is after 100 case record, and our line is flattening now, and our cases or mortality is static. And this is our daily mortality. And this is our recovery. We have a lot of recovered patients, and one of the options for treatment is using the plasma or the antibody. And there is a big project reviewing this possibility and trying to entertain those recovered patients and try to get a benefit from their induced antibody. However, we don't have the serology testing yet. So the most important topic is transmission. So as we know, we have 3 types of transmission, which is contact, droplet, and aerosol or airborne. We believe till now there is clear evidence that coronavirus COVID-19 is a droplet, contact droplet transmission. There have been many talk about airborne transmission or prolonged oralization for the virus and the possibility of transmission. However, we will talk about it when we will touch base on the survival on the surfaces for this virus. So till now, the recommendation, it's a contact droplet transmission, and the precaution should be going with this as gown, gloves, surgical mask, and eye protection or face shield or goggles. However, if we are doing any aerosol generating procedure like collecting respiratory samples, intubation, suctioning, we have to add N95 and waterproof apron or gown. So this is for the healthcare provider. And if we can define the close contact, so usually we would refer to close contact within 6 feet distance from the infected person. And if it's in closed area, with more than 10 to 20 minutes stay in a closed area, regardless the distance. Respiratory droplet is usually transmitted after sneezing or coughing, and looking for the size of this virus, which is usually less than 5 micron. Exactly, it's 0.125 micron. It can travel to 6 feet when we have a sneeze with a high velocity arousal speed. And this is a diagram showing where is it falling the precaution. So the A is the infected person, P exposed person within 1.5 meter or 6 feet, and the red dots is usually representing the large droplet or the large particles, which usually more than 5 microns, where the face mask will be protecting, or surgical mask will be able to protect from this particles. However, the small green particles, if you can see it, this is the usually less than 5 microns, where the surgical mask will be not protective if we have arousal generating or frequently coughing patients. However, the distance is the most important part, where you can see the guy holding C letter. So the social distance is the main strategy to avoid the transmission from infected person, as Dr. Swaydan Ariel mentioned. So we have to rely in avoiding gathering, avoiding meetings, and keeping social distance. So this diagram showing where the small particles less than 5 microns get through the surgical mask, but not through the N95. And this is where the difference between cough, sneeze, and arousal generating procedure, where they can travel to the 1.5 meter or 2 meters, which is 6 feet. So we can see the sneeze, due to the velocity, it can travel longer, but the small parts will fall earlier. So the safe distance is usually 2 meters or 5 feet. We will be protected. If you were in the 2 meter or the 6 feet from the patient, you will be at risk unless you have N95 and full PPE. So this is the one of the common study, and I just make sure to present it because it's the study talk about the airborne possibility or airborne transmission possibility, where it had been published in New England Journal, and they try to generate arousal fluid using a 3-jet nebulizer, which is something incomparable to what had been going during coughing or sneezing, which is excessive oralization. And they collected a sample from the air, surfaces with different surfaces, cover, cardboard, plastic, and stainless steel. And they compare the SARS-CoV-1 to SARS-CoV-2. However, they have the same result when they get an air sample. So both coronavirus, SARS-CoV-1 and SARS-CoV-2, remain hanging in the air for almost 3 hours. And when they compare the cover, it was almost 4 hours, the survival half-life. Plastic reaching 48 hours, stainless steel 72 hours, and on the cardboard it was surviving up to 24 hours. They are almost the same, with just few variability or small variability when we are comparing the cardboard half-life of survival, but comparing the air half-life and hanging on the air, SARS-CoV-1 is similar to SARS-CoV-2. However, nobody entertained the possibility of airborne transmission during the 2002-2003 epidemic. And one of the reasons that why this study is not enough to elude airborne precaution for our patient, this is a scientific study. So they were collecting sample from the air, but they didn't document this sample is infectious. So when they were looking to the sample, the viral inoculum is very low compared to what we have in our respiratory samples when we get a direct contact or direct exposure. And in infection control, we will look to the 3-dimension, which is inoculum, distance, and the time. So they didn't test this, and they didn't expose patient to the area where the patient was there. So they didn't prove the transmission, or they didn't prove the viruses living 48 hours on the plastic. It's infectious, and they didn't prove it to be infecting any person. So it's a scientific paper, it's not a clinical paper, and it's good to be among medical background people, but for the public it's a little bit scary, and that's why we need to make sure everybody understand this, and it's a scientific paper, not clinical paper. What we have as a precaution, so it's very simple. It has been repeated many times since the COVID-19 epidemic, then pandemic declared. It's hand wash, stay home, avoid the contact, and social distance, and cleaning and disinfecting the surfaces. We will not be able to know the people who is infected because many of them, they are asymptomatic. However, we have to make sure to avoid the contact of positive or symptomatic patient, but there is no way to avoid asymptomatic patient without washing hands and keeping the distances. That's why it is the most important precaution that everybody need to be compliant with it. One of the major precautions that I have to mention it for a healthcare provider, because it hasn't been stressed in many guidelines, is how healthcare provider can protect themselves, protect their family when they are working in a positive area or infected area, or dealing with COVID patients and going back home. So there have been many recommendations. So will be the same of washing hands. So we re-emphasize of washing hands and doing that as frequent as you can. One of the things that not mentioned outside Saudi Arabia is pollution and blowing your nose. So I think this is a very important step in our religion, in our culture. However, it's not been documented, but knowing that the virus is usually a respiratory virus, and the main entrance is the nose, and as we know, the virus will be inoculating the mucous membrane, replicating before it's head down into the nasopharynx and the lung. So pollution will be one of the hypotheses where we need to make sure that we do. Definitely during your stay at the healthcare facility, avoid touching your face, and if you do, you have to wash your hands or wash your face after that. Make sure that you will not, or you don't bring any unneeded personal items, laptop, mobiles, handbag to the hospital unless you need it. And when you bring something, you have to disinfect it when you leave the hospital with alcohol wipes. And leave your lab coat inside the workplace if possible. Many area where they have COVID patients area, they have a dressing area where the employee can use disposable scrub or reusable scrub, and they can change their dress when they are leaving the COVID-19 wards or areas. And the other thing is using a shoes cover, and it's recommended to use a specific shoes inside the healthcare facility, and just remove it when you are leaving, and change it with another one. So that's mainly the best recommendation for any healthcare provider to protect himself and his family. So I think that was the most important items in my presentation, and the last page. And thank you again for the invitation, and any questions.
Thank you, Dr. Salim. This was really great. Thank you a lot. So we will leave the question till the end of all the presentation. So our last speaker is Dr. Walid Al-Tuwajri. Dr. Walid is a consultant pediatric neurologist from National Guard Hospital. Dr. Walid is going to highlight for us some of the obstacles facing the pediatric neurologist during COVID-19 era and how to overcome them. Welcome, Dr. Walid, and thank you for being with us.
السلام عليكم ورحمة الله وبركاته. مساء الخير وكل عام وانتم بخير ومبارك عليكم الشهر، وإن شاء الله يا ربي يا كريم تنزاح هذه الجائحة بأقرب فرصة إن شاء الله وأسرع وقت، إن شاء الله يكون العيد عيدين بإذن الله تعالى. I have been asked to talk about the challenges for the pediatric neurologist in this era of COVID-19. I have listed a couple of points on my point of view. First of all, one of the challenges was the virtual clinic. The virtual clinic was a bit challenging for all of the physicians, or either consultants, residents, fellow, nurses, etc. So one of the challenges that we have faced is that you need to call all patients that you have in the clinic. And this is almost, I believe, double or triple the time, and almost double or triple the time that you need to sit with the patient in clinic in intimate way. So that caused challenges to the physician. Second thing is the information that you take from the patients or caregiver. It's not easy. So it take a long time to verify what are these information that needed, etc. The other thing is if you call patient and patients has, let's say, abnormal movements, skin changes, i.e. things that need to be visible to be seen by the physician. So we don't have let's say Skype that is available from the hospital. So we cannot use our own because these are personal. So these are challenges. One of the solution is to give a physician, let's say, a cellular phone, mobile phone, or in the computer, an access for the Skype. At least we can talk to the patients. And not all patients can use this modality of communication. The other thing we face is with the new patients. When you have a new patient referral, 2, 3, 4, 5 patients, and you're calling them, taking information, that is not easy. So time consuming again. You need to have a lot of data. You need to examine the patient, as Dr. Faisal Sweden said, in his talk, that neurology usually is an intimate. So you need to examine the patient in reality. So that causes a difficulty for approaching the patients and approaching the diagnosis, etc. Other limitation or other challenges, let's say if you want to do blood test, detailed test, neuroimaging, neurophysiology testing, EEG, AMG, there is again a difficulty in that because of neurophysiology are closed and only kept for those emergencies, etc. So this make challenges. One of the challenges, in spite of patients have been receiving messages not to come to the clinic, they still come to the clinic for either refill medication or for question, and they don't have view or opening mind about what's going on of the corona risk. Lastly, interesting is the if you phone somebody, or patients, and there is no answer. So the question, how many times you need to call? One time is enough, 2 times, 3 times. So how frequent? My personal advice is 1 time is enough. That's it. No answer, that's it. Because you cannot keep calling every now and then. So one of my colleagues have just talked to me that he received phone calls in the night that he answered back that he was sleeping at the time and he wants to talk to the physician about the case of his kid or whatever. So these are big issue to the physician. So what are the solution that I have suggested myself is that coordinator working in the division can call the patients, make sure that they're okay. I know that she's not a physician, but at least if patient is okay, has no acute problem, had no crisis, had no thing to be talked to the physician about, so it should be marked that patient not need to be called. Patients need medication, so flag that this patient need medication. So I believe the virtual clinic should be limited to a few calls or a few patients to be called. So at least the time that will be consumed, it's really in its place, because you can talk to the patients with intractable epilepsy to increase the dose, reduce the dose, etc. So you have the time. In contrast to calling 20 patients, 25 patients. So that's what I think. I said coordinator call, sort out those patients. You have 4, 5, 6, whatever patients to be called, and then that's it. So this is in general about the virtual clinic. The other challenges that we have faced is there are patients from outside Riyadh, but they are in need to let's say monthly or regular intervention medication, let's say like ACTH, like IVIG, rituximab, pulse steroid therapy, etc. Whatever the procedure is. So, and these patients are from outside Riyadh. So some of these procedures are feasible in their places, so they can do it in their area. Now it comes to communication. Whom to communicate with, and which hospital gonna accept the patient. So that's need really arrangement from the hospital with other institution in that area. And you know, patients are complaining of the challenges. You know, they need to take permission for the curfew, and there are a lot of station, time consuming, you know, physical tiredness, etc. So I think the patients can take or receive the treatment if it's available in their area. And this need a communication on a higher level between institution to institution. And this should be arranged by the institution. One of the challenges also I faced when I was in the service during this COVID-19, the patients coming to the emergency room, and those patients, especially with intractable epilepsy, that are coming in with seizure exacerbation, breakthrough seizures. So we give them rescue medication, and then some of these medication you wish to admit, but because of the current issue and the pressure from the administration, that you defer this admission. So we end up in having the patient coming again after 4 to 6 hours, etc. So this makes us a big challenge. And then to let you know that parents or caregivers are really, mashallah, they are aware, and they don't like the admission, even if you are let's say applying that patient need to be admitted. So really parents, they hesitate to be admitted. But again, we have seen patients coming 2, 3 times, 4 times, and we end up lastly with admitting them with the cautiously. The other point that I put is in the neurology in our institution, I'm sure it is in the other institution, I believe so. We have divided the teams into two teams. One we called COVID team and one non-COVID team. So the non-COVID team, they do their regular rounds, consultation, etc. And if there is any suspicion of a patient or confirmed case of COVID-19, the other team will be called from consultant and resident to follow this patient, even if it's suspected, not proven yet. And I think this is very healthy to protect or prevent cross reaction and transmitting the infection for others. So that's one of the really I think if an institution they didn't follow this, I would suggest that this should be followed. Also, there are a couple of argument. I was asking before, when you admit a patient, do each patient have the test for the coronavirus or not? I believe myself that each should have a test, because there are a medical team, there are nurses, physicians, blah, blah, etc. If this patient turned to be positive after, let's say, a day, and then you have a couple of medical team or that have passed this patient or seen this patient, then you need to test all of these, and these are risky. So I think this is a very cautious. They were applying what you call the score, the coronavirus score, and I'm sure that all of you are aware about the fever, shortness of breath, etc., etc. But I believe for each admission, you should have the test done. And by the way, not all hospitals they are doing this, but I hear now the trend to do all the test for any patient who's admitted to the ward. Now we come back to the resident, the pillar of the hospital, the champions. Actually, the residents that working with us, we try to avoid residents who are not necessarily needed in the service and keep them at home. And this is for their protection and their families. And you end up with this, that the residents are missing some, let's say, rotation in the master rota. And this has been pointed by Dr. Faisal. So the solution is easy for that. Each program director can modify the master rota, especially those who are really have fundamental and basic rotations, like neurophysiology, adult neurology, etc., etc. So it can be modified, can be moved to the next year, or can be moved at the end of the year, inshallah, after coronavirus resolve, or the year after. So I think a program director should have the flexibility and facility to do this. And this has been discussed in our scientific council recently, and this is what we have proposed. The final year, usually, I'm talking about pediatric neurology, but I'm sure it's the same for the adult neurology. They have a bit light rotation in terms of the CTU. They would have it usually early in the rotation, I mean, in the year. So, alhamdulillah, coronavirus started March. So I'm sure that most of them, they have done the basic or the main rotations. Now they have other rotations like neuro-ophthalmology, neuropathology, etc. So these, what we agreed on, that it can be done through the webinar with those expertise. So the resident need to attend the lectures, participate, etc. So this can at least replace whatever they are, what are the deficiencies that they will have in the rotation. My advice to the residents from my practice, they, as I said, they are really the champions, but however, some of the residents are not really taking care or precautions. So I have seen some residents, they are not using the mask. all health workers are expected to wear at least the mask, and this is for themselves, their family, and the patients. So I just advise or just remind my colleagues and my friends, the residents, to be cautious and to wear the mask, because they are in intimate contact more than the consultants, and this is the real practice. So I would advise them that they should have the precautions for their health. Interesting, just the last point to end it up, to talk that with this era of coronavirus, I'm sure myself and my colleagues, the phone, the WhatsApp, the consultation has been increased. I have received calls, I have received WhatsApp from relatives, friends, and now those who I don't know from where they get my number. But because if there is no clinic, private clinics are closed. So interestingly, I received many consultation in this issue. That's what I do have. And I would like to say that, you know, I heard the word social distancing, and I'm sure that this is a wrong word. It doesn't mean that you need to be away from your society or your relatives. You can contact them by phone, etc., or all communication tools that are available. The correct words are physical distancing. So it should be just away a meter or more than a meter from the person, and this is the right word. Thank you very much. I think that I will end up my talk. And thanks for the invitation, Dr. Khalid and Dr. Fahad.
Thank you, Dr. Walid. That was very informative. Thanks a lot. So we will open the floor for some questions. So we received like a lot of questions. So my first question is to Dr. Faisal. Any update about ACE2 receptor role in COVID-19 neuroinfection? That's from Dr. Bamaga.
This receptor is probably well known in the lungs, in the respiratory system, and also in the vessels. To my knowledge, there is nothing about the neurological manifestation association with this receptor. However, there is increased risk of stroke, cerebrovascular events if the patient is non-hypertensive or cardiovascular patient, but not specific to the CNS.
Also, another question for Dr. Faisal. A lot of these neurological cases are attributed to COVID-19, and actually they didn't show an evidence of CNS infection. They showed like a positive PCR from like nasopharyngeal aspirate, but didn't show an evidence of CNS infection. Any comment?
True. This is actually one of the hypotheses they had, that there's a direct invasion, and the second is the cytokine storm, which is the inflammatory or autoimmune response, and that's involved the CNS. So there's two scenarios: direct invasion and the autoimmune pathophysiology.
Thank you. We have a question to Dr. Salim. Do you think the virus genotype in KSA is less deadly than the one in China or States? So is it the genotype is different?
Unfortunately, we didn't do any genotype yet in Saudi Arabia. And there have been many theories why we didn't have a lot of mortality, alhamdulillah. But there is no clear theory. Some of the theories, they claim the BCG vaccine have been protecting many nations and countries, but I think this is only observational thoughts and hypotheses, but there is no clear answer why many countries they have been affected compared to the other country.
Right. Also, this question is to Dr. Salim. I received this question maybe 5 times till now. What are the precautions that we should take as a pediatric neurologist in the regular ambulatory care? What should we do to protect ourselves?
When we are dealing with regular patients or COVID patients? I wouldn't expect a regular COVID patient to be in the clinic, right?
No, I mean like for these children, most of them are asymptomatic, right? If they have the COVID.
Yeah. So there have been many steps or procedures that have been taken to minimize the in-hospital transmission. Dr. Twajri mentioned that all patients coming, they are having a risk, and we have this in our hospital. So many hospitals, they have been getting a lot of patients, companions, visitor without any symptoms, or sometimes with the mild symptom, and they have been missed, and they went to the lab, went to the radiology, went to the clinic. So
Right.
it's many layer, Khalid. So I think first of all, we have to utilize or re-emphasize the utilization of telemedicine. Many hospitals, they have already virtual clinic, and we were luckily having a virtual clinic in 19 centers around the kingdom, and we have been using this for a time. So we use this especially during COVID-19 pandemic, and it helped a lot. So we minimize the flow of patients to the hospital. Second layer is communicating with the patient, sending message if you have any symptoms. Unfortunately, many patients or sitters, usually big hospital in Riyadh, usually their population is either immunocompromised patient, old patients, transplant patients. So they usually need companions, and many hospitals, they take care of the patient, they ask the patient, they do SARS score for the patient, but they forget to do it for the companions, where they have a higher risk to carry the virus without symptom. Many of our patients, if they have the virus, will be symptomatic because they are either having comorbidity or they are immunocompromised. So the second layer to communicate with the patients, if any one of the companions or the visitor or the patient have symptom, not to report to the clinic or to the outpatient, just go to the emergency. Third layer is checking the temperature. The last one is SARS score. So one of the initiatives that some hospitals, they do SARS score for any patients coming to the clinic, coming to the radiology, coming to the lab, coming for the EEG, coming for any visit. We have to do a SARS score and take a detailed history. Again, we still have patients without any symptom, and they could be transmitting the virus. So this is the area where you can do a lot. However, during the clinic, you have to make a space, you have to make a distance. Try to use the PPE, mask, gloves, wash your hands, disinfect the clinic during this time. But it's only a procedure to mitigate the risk, but there is no way to make it zero unless you didn't see any patients. So we are in a healthcare facility, and we have been there to see patients. So there is risk, but I think this procedure will minimize it to a very minimal risk at the end, inshallah.
Thank you. There is a question to Dr. Walid. Any clear regulations for the virtual clinic, and especially medico-legally, what are the consequences if you missed a sign or symptom in a patient because you are using the telemedicine or through like an application?
Wallahi, Dr. Khalid, to my knowledge, there is no, because this was a very acute stuff, and I think each institution have its own rule. So to my knowledge, there is no clear, guidelines or whatever through the virtual clinic, what should be done, what not to be done. I have seen in the practice, people are not calling every patient, some they are calling all, some they are do follow-up phone calls for patients within a week, etc. So at the end, the bottom line, there is no clear, guidelines, whatever. But in general, it's a phone call. Patient didn't answer. I think myself, medical legally, if patient there is no answer, you don't need to call twice, thrice, unless patient's really sick or patient really seeked through the coordinator or whatever that need to talk to a doctor. That's the only thing. Medical legally, I don't think there is, if you miss a sign or symptoms, I don't think it's a recorded, by the way, it's a recorded call. But usually it's both resident consultant attending the same conversation whatever the resident called or the consultant called, usually they talk to the patient. Usually speaker is put on. So there are two, at least, physician can hear the conversation. Generally, I don't think you are talking about sign without videos, without, so it's not, I don't think if any consequence. I think the virtual clinic is a positive thing from the physician to the community. I don't think physician should be, let's say, punished for that. At the end, I don't think so. If you allow me, Khalid, two comments I forget that for the resident. The session, I mean, for the during, I mean, the teaching, the academic half days, etc., the continuous teaching, I think it has stopped in all or most of the centers. And I think as we have, right, we are doing it now on the Zoom, whatever, or other communication tools, it can be done. Maybe because of the difficulties, probably all the centers in the training, they can combine, let's say, in 1 week, 2 activities, and for all the centers, and residents should attend, and 1 speaker. I think that's one of the solution. Lastly, I mean, the take-home message of this lecture today of both Dr. Faisal and Dr. Al-Ghamdi. We mentioned neurological complication or presentation of COVID. Now, if you have patient in the emergency room presenting with loss of consciousness, seizure, whatever, pediatric or adult, chorea, seizure, stroke, etc. So the question, patient will be admitted. So he doesn't have, the score of, he doesn't have fever, he doesn't have shortness of breath, blah, blah, etc. So the threshold to test COVID, it should be lower. That's my point of view. So any admission, at least under neuro, should have a COVID test. And this was an argument with the ID, and probably Dr. Salim can comment on that. I think there was a limitation of the test. I said, I appreciate that, but now I think we received a lot of tools. So I think, because it is very important, at least the admissions, because there will be a contact of many medical personnel. The emergency, well, maybe if he's discharged, you can argue, but for the admission, that's it. Thank you very much, and Asif Lil-Itala.
Thank you. I have a question
to add to Dr. Walid. So thank you, Dr. Walid, for raising this. So I think this go back to the availability of the test, and the availability of the test is a major issue. I mean, at the national level, but I know many centers they screen patients, or they do COVID for admissions. We are doing this at our hospital, so no admission without COVID, even elective, even emergency. So anyone getting inside the hospital, staying, he need to get a positive test. Even the sitter, if you have a patient coming with his mom, the mom need to be tested. So many hospitals, they might not have the test, but the principle is to do it for everyone. However, if there is a limitation, it's usually, so limitation is a limitation. You wouldn't be able to overcome.
Thank you. Dr. Salim, there is a question for you. Recent data shows that the peak of COVID is by the end of June. Any chance that we will get another peak? What do you think about that?
So there have been many prediction, and as I said before, they all depend on previous, either two things, either to depend on previous or similar countries, experience from China, Italy, Japan, Singapore, and many countries similar to our population, similar to all the measures that we have been taken, and roughly all the countries, the peak is usually in the second month after, for example, for incubation period. But there is no two countries did the same precaution. So many countries, they overcome the peak within 2 months, but they did a lot of testing. We didn't do a lot of testing till the last week. So we are not similar to any country. So there is no clear prediction, or I can say nobody can predict that. Many people, they depend on R0 and reproduction number. Again, the reproduction number is calculated from numbers where nobody can make sure this number is real. It can be even double. So to be honest with you, there is no clear prediction, but seeing our curve, and this is the only way to know where we are heading, is seeing our data, seeing our curve. And I think with the extensive or mass screening or national level screening, if we have 2 weeks screening, we'll be able to predict where we are going. Unfortunately, we are doing a lot of serology. Serology is a big tool to know how many people are protected from the community. I expect a lot of people, they have the virus at one time and they were asymptomatic and they are now protected. So your herd immunity is determining where is the cycle of the virus will end. So we are still missing some cubics from our final shape, but it's not clear, to be honest with you, Khaled. They can't say exact duration.
Yeah, fair enough. We'll take a question from Dr.
Question to Dr. Faisal, please, regarding the smell involvement. It was noticed that it is an early sign. So is it related like to central involvement for the nerve, or there is something related to mucosal involvement?
Well, what we have is the hypothesis of the, invasion in the mucosa and the nasopharynx, and then they go through the olfactory nerve to the bulb through a demyelinating, ascending through the axons and causing demyelination of the olfactory bulb. So this is probably well known in many viruses, not only the coronavirus. It's also proposed in herpes simplex as well. So it's a process of ascending through the axons of the olfactory nerve to the olfactory bulb with the demyelination process that lead to the loss of the smell sense. And also there is also case report about loss of taste as well, not only smell.
I agree with Dr. Waleed regarding the challenges. I just want to share some of positive things that done in some of the hospitals regarding medication delivery, and this is very important point. However, we have challenges also in the controlled prescription, and this is very difficult because, you know, the controlled prescription has to be received by the patient himself in the same pharmacy. We were proposing to, or the Ministry of Health was proposing to give the medication to nearby primary care center or nearby hospital to the patient. So the agency will deliver the medication to the nearby hospital or clinic. Then the parent will go to this clinic and receive the controlled medication and sign the paper. And that's one of the challenges really in delivering the medication to the patient. Other thing, the virtual clinic, there is like a trial in our hospital. Actually, we don't try it in pediatric neurology, but in family medicine, what they do Zoom like interview with video. They send the message before to the patient. They send him a message that you will receive a phone call. What do you prefer? You prefer a phone call or video with phone, or a message? Then he will reply that through the central number. They have it in the clinic. And then they run the clinic on the same day or the day after. And the electronic health system, if it is available, that's very, I think, positive for us, because in our hospital, we used to review the patient that's coming to the clinic. For example, I have clinic tomorrow. I review all the patient in the electronic health system. And I make like a preliminary plan that will save time in the clinic when I'm calling the patient or even the resident with me in the clinic. And that's very important to involve the resident in training under supervision of the consultant to communicate, to call in the presence of the consultant, even through the phone call at the same time. They can share the phone call together at the same time. I mean, shared call to the parent of the patient. This is one of things that you can do it in the virtual clinic. Still, the difficulties is there, but we are passing a difficult time. We are trying our best to help our patient and our community And again, we have to be very, cautious regarding the precaution that we have to do for ourselves and our trainee in dealing with patient during this difficult time.
Khalid, let's just comment if you allow me. Quick comments. For the control medication, I think myself, if I am a decision maker in this crisis, the rules of signing and giving the ID should be out. I give 1 month supply, okay, and then send it whatever. I think this is a crisis, 2, 3, 4, 5 months. It's not permanent. All rules that has been done in the past should be devoted at this time. And it's a 1 month, and this is what they usually do. So I think you should weigh both sides. The other thing, Dr. Fahad, the Zoom is okay, but I mean, it's a very time consuming. I wouldn't consider a Zoom call for each patient. I think a screening should be done for the patients. There are referrals that, let's say a headache. Why should I Zoom patient with the referral of headache, etc.? So I would say, yes, I agree, it is good, but I think it should be limited, probably for those new patients with, abnormal movement or whatever, skin, anything that can be visible, but not all patient. That's my opinion. Lastly, معلش لو طولت آسف، سؤال سريع للدكتور سالم. Very quick question to Dr. Salim. It's regarding the R0. Now we know that our country, they are doing the mass testing, i.e. so that's why the number is increasing. So I'm sure that not all countries are doing it, and that's why probably we have this number. But when you're calculating the R0, if you are not doing the mass testing, the R0 will be low and low. So are we using this R0 even with the mass testing, or, you know what I mean? If let's say 1,000, they are positive, 750, they are they are positive because of the mass screening. So we left up with 250. So that makes the R0 is very low. So my question, R0, 0.8, 1, whatever, below 1. So are we including these patients, or are we excluding this patient? And you can tell us, you can comment on the efficacy of this.
Okay, so it's good question, Dr. Walid, and that's why I alluded that R0 is not a very it's not very specific. It's not very informative. It's good to guide, but it's new cases to the susceptible patient. And even if we know exactly how many positive patients, if we do mass screening, so we will do mass testing for example 2,000, and if we get 500 of them positive, we can generalize this to have, for example, 25% of our population is positive. However, we don't know who's the susceptible population. If we do, for example, serology for 2,000 asymptomatic people, we might find 1,000 of them are immune and they get the virus at one time. So the R0 will be totally different. So even if we were very sure about the positive cases, either do mass screening or you screen all the patients, you are not sure who's the susceptible population. We don't know who's immune in our community. So R0 is not a very specific at this time, at this pandemic. It's just, it could be a rough estimation, but it's not the best tool to do it now. And I know many people, they rely on it, but I think it's not the real number that we can depend on. So they are doing the mass screening not to get the R0, but to try to slow the progression and try to diagnose positive cases and keep them socially distancing and prevent the transmission. But it's not to get the R0 and predict when the pandemic will, or the epidemic outbreak will declare off.
Are these numbers alarming? The 1,000, the one with the mass test, are these numbers alarming?
For me, no. because expected. You are doing more screening, you will get a lot of positive. So to be honest with you, I was expecting a very big jump of the new cases after mass screening, but alhamdulillah, we didn't jump a lot. So it's not alarming. Expected, and even it's below the expectation, to be honest with you.
When the life will be back to normal? August? الله أعلم أنا عارف. بس يعني I know nobody know.
Will be soon, because there is a lot of consideration. It's not, to be honest with you, the decision to open life again is not a medical decision. Okay, so we are mitigating the risk, we are passing the peak, and definitely the virus will continue. So it's usually balancing the benefit and the risk of lockdown, and this is what all countries are doing. And we start to open it partially. So I think we will be seeing a lot of opening with the time after getting the mass testing and knowing the picture better than before. I would expect in before Eid, inshallah, there will be a lot of opening. I hope. لا تنقلونها عني.
إن شاء الله الله يسمع منك. Thank you all. At the end of this webinar, the Saudi Pediatric Neurology Society would like to thank all our guest speakers, Dr. Faisal Al-Suwaidan, Dr. Salim Al-Ghamdi, and Dr. Walid Al-Tuwajri. جزاكم الله خيرا ونفع الله بكم وبعلمكم وجعله في موازين أعمالكم. I'll give the mic to Dr. Fahad to end.
Thank you, Khalid. Thank you all the group. It was very interesting talk. I really thank you all, and thank you also. I would like to thank Event Tرووب for the technical support. And inshallah, there will be a future webinar will be announced later, inshallah. And stay home and be safe. أتمنى لكم جميعا الصحة والسلامة. السلام عليكم ورحمة الله تعالى وبركاته.
وعليكم السلام ورحمة الله وبركاته.